Our lecture today is about lower limb fractures, including patella fractures, leg fractures, and foot fractures. We will start with the patella. The patella, also known as the kneecap, is a flat, circular, triangular bone which articulates with the femur and covers and protects the anterior articular surface of the knee joint. The patella is the largest sesamoid bone in the body. Bipartite patella is a condition where the patella is composed of two separate bones instead of fusing together as normally occurs in early childhood. The bone of the patella remains separated. The condition occurs in approximately 1 to 2% of the population. It is often asymptomatic and most commonly diagnosed as an incidental finding on the X-ray, as these X-rays show us. The primary role of the patella is knee extension to improve the quadriceps efficiency. The patella increases the leverage that the quadriceps tendon can exert on the femur by increasing the angle at which it acts. The patella is attached to the tendon of the quadriceps femoris muscle, which contracts to extend the knee. The patella is stabilized by the insertion of the horizontal fibers of the vastus medialis and by the prominence of the lateral femoral condyle, which prevent lateral dislocation during flexion. The retinacular fiber of the patella also stabilizes it during exercise. The mechanism of injury of the patella, either direct impact injury, which occurs from fall, or dashboard injury and causes failure in compression, or indirect eccentric contraction, which occurs from rapid knee flexion against contracted quadriceps muscle, which causes failure in tension. The pattern of patella fracture is either undisplaced fracture, transverse fracture, lower or upper pole fracture, comminuted undisplaced fracture, comminuted displaced fracture, vertical fracture, and osteochondral fracture. The management of patella fracture depends on the integrity of the extensor mechanism. If the extensor mechanism is intact and the patient is able to perform straight leg raise, most likely the management will be non-operative by cylindrical cast from above the ankle to above the knee, or in non-displaced or minimally displaced fracture that the extensor mechanism is still intact, we prefer the non-operative treatment. If the extensor mechanism is not intact, there is disruption, then the best way of management is to open reduction and internally fixing the patella to have the normal function of the patella and normal extension of the knee. Complications of patella fracture include loss of the range of motion, which is the most common complication, loss of reduction, infection after operative treatment, secondary post-traumatic patellofemoral osteoarthritis, and the need for hardware removal. Proximal tibia fracture. Proximal tibia is composed of the medial tibial plateau and the lateral tibial plateau, which is separated by the tibial spine. Proximal tibia fracture are a common fracture of the tibia that are associated with a high rate of soft tissue complication. The mechanism of injury is either a low energy, which results in a torsional injury and spiral oblique fracture, or indirect trauma. High energy trauma, which results from direct trauma, associate usually with compartment syndrome, soft tissue injury, which complicate the outcome of the patient. To classify proximal tibia fracture, we use Schatzker classification. Type 1 is a split of the lateral tibial plateau. Type 2 is a split of the lateral tibial plateau with articular depression. Type 3 is just central depressions of the tibial plateau without split. Type 4 is a split fracture of the medial tibial plateau. Type 5 is bicondylar fracture. Type 6 is dissociation of the metaphyseal and diaphyseal junction. CT scan is very helpful in accurately defining the extent of the bony injury and facilitates the orthopedic planning and intervention. It gives us a better view for the joint depression to classify the fracture according to the Schatzker classifications, and which helps us in the management and in the operative treatment. When treating proximal tibia fracture, we have to pay attention for the mechanism of injury. Either it is low energy trauma or high energy trauma. Also, we have to pay attention for the associated soft tissue complication and compartment syndrome. Non-operative treatment by cast immobilization is used for low energy fracture with acceptable alignment. We can use a cast, then move to a hinge knee brace. Operative treatment is used for high energy trauma and when there is articular element of the fracture. The treatment is usually to open reduction, to restore the knee joint, and then fixing the proximal tibia. Sometimes we use bone graft to elevate the joints and to promote healing. Complications of a proximal tibia fracture, tibial plateau fracture include soft tissue complications, compartment syndrome, infection, and mainly after surgical intervention, post-traumatic secondary osteoarthritis, decrease in the range of the motion of the knee, associated meniscus and ligamentous injury, and neurovascular bundle injury. Tibial shaft fracture. Since approximately 1/3 of the tibia lies directly beneath the skin, open fractures are common compared to other long bones. These open fractures are most commonly caused by high-velocity trauma, motor vehicle collision, while closed fracture most commonly occur from sports injury or falls. For classification of tibia fracture, we use the fracture patterns, either it is simple, butterfly, or comminuted. A1 is for spiral simple fracture. A2 is for oblique fracture. A3 is a simple transverse fracture. B1 is a butterfly by torsion and spiral element of the fracture. B2 is butterfly by bending. B3 is butterfly several by bending. C1 is comminuted by torsion. C2 is a segmental fracture, and C3 is a crush injury. Management of tibia fracture depends whether the fracture is closed or open. In a closed fracture with acceptable alignment, we can use the non-operative treatment. In open fracture and in a non-acceptable alignment of the treatment, we have to move to surgery. If the fracture is open, we have to classify according to the Gastello classification and start with antibiotic, adequate irrigation, analgesia, ATS, and then move to the next step of surgery. We can fix the tibia by intramedullary nailing, as the picture on the right shows, or with a plate and screws. Complications of tibial shaft fracture. Infections after open fractures and surgical intervention. Delayed union and non-union. Since the shin of the tibia is subcutaneous and has no soft tissue coverage, malunion and deformity, which will result in ankle osteoarthritis, local discomfort related to the metal implants, and neurovascular bundle injury. The ankle joint is formed between the articulation of the distal fibula, distal tibia, and the upper dome of the talus. The upper dome of the talus is wider anteriorly than posteriorly. That's why the ankle joint is more stable in dorsiflexion than plantar flexion. In the ankle joint, we have three malleoli. The lateral malleolus, which is formed from the distal fibula, the medial and the posterior malleoli, which is formed from the distal tibia. The syndesmosis is a fibrous joint held together by ligaments. It is located near the ankle joint between the tibia and the distal fibula. That's why it's called the distal tibiofibular syndesmosis. It's actually made up of several ligaments. The primary ones are the anterior inferior tibiofibular ligament, the posterior inferior tibiofibular ligament, the interosseous ligament,
and the transverse tibiofibular ligament. The syndesmosis ligament acts as a shock absorber, providing stability and support for the ankle. Its main job is to align the tibia and the fibula and keep them from spreading too far apart from each other. We have parameters on the X-ray that will help us to assess the stability of the ankle joint. The medial clear space between the medial malleolus and the talus should be less than 4 mm, and the tibiofibular clear space should be less than 6 mm. Any increase in these spaces indicate syndesmosis injury and instability of the ankle joint with deltoid ligament disruption. The injury patterns can be isolated medial malleolus fracture or isolated lateral malleolus fracture, bimalleolar and bimalleolar equivalent fracture, posterior malleolus fracture, and trimalleolar fracture. We use Weber classification to classify ankle fracture. This classification depends on the level of fibular fracture relative to the syndesmosis. If the fibular fracture is below the syndesmosis, this is Weber A. If the level of the syndesmosis is at the level of fibular fracture, this is Weber B. And if the fibular fracture is above the syndesmosis, this is Weber type C. Non-operative treatment by short leg cast is indicated in isolated, non-displaced medial malleolus fracture or tip avulsions, isolated lateral malleolus fracture with less than 3 mm displacement and no talar shift, bimalleolar fracture if elderly or unable to undergo surgical intervention, posterior malleolar fracture with less than 25% of joint involvement or less than 2 mm of step off. Open reduction and internal fixation of ankle fracture is indicated in antelar displacement, displaced isolated medial malleolar fracture, displaced isolated lateral malleolar fracture, bimalleolar fracture and bimalleolar equivalent fracture, posterior malleolar fracture with more than 25% or more than 2 mm step off, open fractures, and inpatient with malleolar non-unions.
Complications of ankle fracture include soft tissue complications and compartment syndrome, infection, malunion, non-union, and secondary post-traumatic arthritis of the ankle joint.
Pilon fracture or tibia plafond fracture. Plafond means the ceiling. It is the horizontal distal aspect of the tibia articulating with the talus. Pilon came from the device on the right side of the image, which indicates the mechanism of injury that the talus is driven into the ankle joint and causes the break in the horizontal distal articulation of the tibia. The mechanism of injury can be low energy trauma and high energy trauma. In high-energy trauma, soft tissue will complicate the management of the patients, and it will increase the risk of complication. We can view Pilon fracture as a soft tissue injury associated with a fractured bone. CT scan is a must in tibia plafond fracture to assess the articular involvements and to help us with classifying Pilon fracture. It will help in surgical planning and facilitate the operative treatment. We use Ruedi and Allgower classification to classify distal tibia plafond fracture. Type 1 is a cleavage fracture with no major articular disruption. Type 2 is a fracture dislocation with major articular surface disruption without comminution. Type 3 is a major articular disruption with impacted and comminuted fracture dislocation. Management of tibia plafond fracture, either non-operative by immobilization, unstable fracture patterns without articular surface displacement, and in patients who are critically ill or non-ambulatory patients, and in patients with significant risk of skin problems, such as diabetic patient with vascular disease, and neuropathy. Operative treatment. Here is the role of temporizing spanning external fixation across the ankle joint in the acute management, which provides stabilization to allow for soft tissue healing. In fractures with significant joint depression or displacement, and we have to leave the external fixator until the swelling resolves. This is generally from 10 to 14 days. Open reduction internal fixation is the definitive fixation for the majority of Pilon fractures. Limited or definitive ORIF can be performed acutely with low complications in certain situations. Complications: wound slough in 10% of the patient, dehiscence of the wound in 9 to 30% of the patient, and here we have to wait for the soft tissue edema to subside before open reduction internal fixation, and this takes around 1 to 2 weeks. Infection in 5 to 15% of the patient, varus malunion, non-union, post-traumatic arthritis, chondrolysis, and stiffness. The foot is composed of 3 regions: the hindfoot, the midfoot, and the forefoot. The hindfoot is composed of a talus and the calcaneus, articulating with each other in the subtalar joint. The talus will articulate anteriorly with the midfoot with the navicular bone, and the calcaneus will articulate anteriorly with the cuboid bone. The joint between the talus calcaneus and navicular cuboid is called the Schatzker joint. The movement at the subtalar joint is the pronation and supination movement, and the subtalar joint is stabilized by interosseous talocalcaneal ligament. The joint between the hindfoot and the midfoot is called the Schatzker joint, or
transverse tarsal joint. The second region of the foot is the midfoot. It is composed of the navicular bone, cuboid bone, and the three cuneiform bones. It articulates with the forefoot through the Lisfranc joint. And one of the most important stabilizer for the foot is the Lisfranc ligament, which is between the medial cuneiform and the base of the second metatarsal bone. The third region of the foot is the forefoot. It is composed of the 5 metatarsal bones and the phalanges of the toes. Calcaneus fracture. It is the most commonly fractured tarsal bone with high morbidity and disability, which is associated with displaced intra-articular fractures. Calcaneus is one of the hindfoot bone which articulate anteriorly with the cuboid bone, and the superior surface articulate with the talus bone. Extra-articular fracture comprise 25%, and intra-articular fracture comprise around 75% of these fracture. We use standard classification, which is based on the number of articular fragments seen on the coronal CT scan at the widest point of the posterior facet. Type 1 is an intra-articular fracture with less than 2 mm displacement. Type 2 is one primary fracture line on the coronal CT scan. Type 3 is two primary fracture lines, and type 4 is 3 or more primary fracture lines. Management of calcaneal fracture is either non-operative for extra-articular fracture with acceptable alignment and intra-articular fracture with acceptable alignment. Operative treatment with either open reduction internal fixation or by percutaneous screw fixation is used when there is non-acceptable articular alignment of the subtalar joint. Complications of calcaneal fracture include compartment syndrome, wound dehiscence and infection after open reduction and internal fixation. Diabetes and heavy smoking increase the risk of wound dehiscence and infection. Malunion and deformity, arthritis of the hind foot, and chronic persistent pain. Talus fracture. The talus is the second largest of the tarsal bones. It is also one of the bones in the human body with the highest percentage of its surface area covered by articular cartilage. It is also unusual bone in that it has a retrograde blood supply, like scaphoid in the wrist. Arterial blood enters the bone at the distal end of the talus. The talus articulates superiorly with the tibia in the ankle joint. Anteriorly, it articulates with the navicular bone, and the inferior surface of the talus articulates with the calcaneus. The talus is composed of talar body, lateral process, talar head, and talar neck. Talar body fractures accounts for 13 to 23rd of talus fracture. Lateral processive fracture account for 10% of talus fracture. Talar head fracture is the least common of the talus fracture. Treatment of this injury is non-operative for non-displaced fracture, which is less than 2 mm, and short-leg cast for 6 weeks. If the displacement is more than 2 mm, then we will move to the operative treatment. Talar neck fracture is the most common fracture of the talus. The mechanism is either high energy injury with forced dorsiflexion and axial load. We use Hawkins classification to classify Talar neck fracture. This classification can predict the outcome of Talar neck fracture and the avascular necrosis rate. Type 1 Hawkins is a non-displaced fracture. Type 2 is a subtalar dislocation fracture of the talar neck. Type 3 is a subtalar and tibiotalar dislocation. Type 4 is a subtalar, tibiotalar, and talonavicular fracture dislocation. The management of talar neck fracture is non-operative treatment by short leg cast for 8 to 12 weeks and non-weight bearing for the first 6 weeks. This type of management is used for Hawkins type 1 classification and operative treatment for type 2, 3, and 4 to decrease the risk of avascular necrosis. Complications is avascular necrosis, talonavicular arthritis, chronic pain from symptomatic non-union, and subtalar arthritis. A Lisfranc injury is a tarso-metatarsal fracture dislocation characterized by traumatic disruption between the articulation of the medial cuneiform and the base of the second metatarsal bone. The mechanism of injury is usually caused by indirect rotational force and axial load through a hyperplantar flexed forefoot. The image on the left side is a normal foot AP X-ray. It shows that the first metatarsal is aligned with the medial cuneiform and the second metatarsal is aligned with the intermediate cuneiform. The image on the right, which shows Lisfranc fracture and fracture at the base of the second metatarsal. The space between the first and second metatarsal bone increase and is abnormal, and the second metatarsal bone is not well aligned with the intermediate cuneiform. Management of Lisfranc fracture: non-operative by cast immobilization for 8 weeks. The indication for the non-operative treatment is no displacement on weight bearing and stress radiographs and no evidence of bony injury on CT scan. Usually this is a dorsal sprains. In non-ambulatory patients, in patients with the presence of serious vascular disease, and in severe peripheral neuropathy. Other than that,
we will move to the operative treatment by open reduction, restoration of the Lisfranc joint, which is an important joint for the stability of the arches of the foot, and internal fixation. Complications of Lisfranc fracture, soft tissue complications, and compartment syndrome. Post-traumatic secondary osteoarthritis is the most common complication, which may cause altered gait and long-term disability. Non-union, which is a non-common complication, and a chronic residual pain even after getting perfect anatomical reduction and fixation of the Lisfranc fracture. Metatarsal fracture. Each of the metatarsal bone is composed of head, body, and base. The fifth metatarsal, which is the most common fracture metatarsal bone, has the insertion of peroneus tertius tendon and peroneus brevis tendon at its base. The fifth metatarsal bone has 5 types of fracture: head fracture, shaft fracture, stress fracture, Jones fracture, and tuberosity avulsion fracture. At the junction between the metaphyseal and diaphyseal, there is a vascular watershed area, which increases the rate of non-union. And the non-union rate for this zone is as high as 15 to 30%. Base of fifth metatarsal fracture account for 25% of all metatarsal fracture, of which 90% are zone 1 fracture, I mean tuberosity avulsion fracture. The mechanism of injury of metatarsal fracture is either direct crush injury, which may have significant associated soft tissue injury, or indirect mechanism, which is the most common, which occurs with forefoot fixed and hindfoot or leg rotating. Metatarsal fracture are among the most common injuries of the foot. The goals of the treatment include maintenance of the transverse and longitudinal arches of the forefoot to restore alignment to allow for normal force transmission across the metatarsal heads. It is either non-operative or operative. The indication for operative treatment are open fractures, first metatarsal fracture with any displacement because there is no intermetatarsal ligament support, and 30 to 50% of the weight bearing with gait is transmitted through the first metatarsal. And in central metatarsal, any sagittally plane deformity more than 10 degrees or more than 4 mm translation. Multiple fractures are indication for operative treatment. Complications of metatarsal fracture include soft tissue complications and compartment syndrome, metatarsalgia from malunion. Metatarsalgia is pain in the area of metatarsophalangeal joints, delayed union, non-union, and refracture. Phalangeal fractures. The big toe is composed of proximal and distal phalanges. From the second toe to the fifth toe, they are composed of proximal, middle, and distal phalanges. Toes fractures are relatively common and frequently managed by primary care and emergency physician. It accounts around 10% of cases treated by primary care and emergency physicians. Of these, over 60 to 75% involve these smaller toes. Management. Displaced fractures of lesser toes should be treated with reduction and body taping. Patients with displaced fractures of the first toe often require more rigid stabilization of the reduction. Complications of phalangeal toes fracture. A common complication of toe fractures is persistent pain and decreased tolerance for activity. Malunion, degenerative joint disease in intra-articular phalangeal fracture. Osteomyelitis is a potential complication of open fractures. Thank you for being in Lower Limb Fractures Part 2.